Historically, the management of type 2 diabetes focused on isolated glycemic control. Clinicians titrated medications to achieve specific downward targets in HbA1c. Semaglutide introduced a different trajectory. Upon subcutaneous injection, the molecule migrates into the bloodstream and initiates interactions across multiple physiological pathways. Pharmacologically, the drug is a GLP-1 receptor agonist designed as a synthetic analog of the naturally occurring hormone. While the historical focus remained on glucose, semaglutide is applied to both type 2 diabetes and weight management. This dual application targets a specific clinical objective, bridging the gap between blood glucose lowering and the broader management of cardiometabolic risk. To understand the prescribing logic behind this drug, we must examine its physiological effects starting at the receptor level. The drug targets 3 distinct systemic nodes: the pancreas, the gastrointestinal tract, and the brain. This anatomical map illustrates the drug's physiological influence across these 3 distinct networks. Mapping this multi-system interaction explains how semaglutide lowers glucose without triggering severe hypoglycemia, while simultaneously driving weight loss. The primary site of glycemic control is found within the pancreatic islet cells. At this level, semaglutide binds to GLP-1 receptors on the islet cell membrane. This mechanism remains dormant until triggered by elevated blood glucose levels. Once triggered, it initiates a dual action response. Insulin secretion increases, while glucagon secretion, which normally raises blood sugar, is suppressed. This results in the effective lowering of both fasting and postprandial glucose. As blood glucose levels return to a normal range, the drug's action pauses. This makes the insulin and glucagon response strictly glucose-dependent. Because the drug's action scales with glucose levels, semaglutide carries a low risk of hypoglycemia when used as monotherapy. The drug's influence extends peripherally to the gastrointestinal tract, specifically the stomach. In the gut, semaglutide delays early gastric emptying, slowing the rate at which ingested glucose enters the circulation. Centrally, the molecule targets the appetite-regulating areas of the brain. In the hypothalamus, receptor activation acts as a neural dampener. This leads to a reduction in hunger, cravings, and total energy intake. These gastrointestinal and central effects are the primary drivers of reduced body weight and body fat. This weight loss axis serves as the catalyst for broader cardiometabolic improvements, including lowered systolic blood pressure and improved lipid profiles. These effects are governed by the drug's specific pharmacokinetic timeline. Subcutaneous semaglutide has a long half-life of approximately 1 week. This duration allows for the convenience of once-weekly dosing. While fasting glucose may drop early in treatment, full HbA1c reductions and weight effects take several weeks to materialize. To manage this accumulation, prescribers titrate doses upward gradually, ensuring patient tolerability to the systemic effects. While the standalone mechanism is highly regulated, clinical risk increases when semaglutide is used alongside other medications. The safety profile seen in monotherapy changes when the drug is combined with other glycemic agents. Combining semaglutide with insulin or sulfonylureas creates a synergistic risk, significantly increasing the likelihood of hypoglycemia. Consequently, clinicians often reduce the doses of these concurrent medications before starting semaglutide. The gastric delay mechanism also carries systemic implications for oral drugs. Slowed gastric emptying can alter the absorption rate of oral medicines, which requires monitoring for drugs that need rapid uptake. There is also a clinical redundancy between GLP-1 receptor agonists and DPP-4 inhibitors. Combining these 2 classes is not recommended, as they act on overlapping pathways and provide no added clinical benefit. Furthermore, gastrointestinal side effects like vomiting can lead to dehydration, which may worsen renal function in susceptible patients. Because semaglutide acts on multiple systems, its side effects can physically alter the pharmacokinetics and safety of a patient's concurrent medications. These pharmacological characteristics determine the drug's placement within NICE treatment guidelines. GLP-1 receptor agonists are generally used as add-on therapies rather than first-line interventions for most patients. Within the diabetes treatment algorithm, semaglutide occupies a specific insertion point. It is recommended as an initial add-on to metformin and an SGLT2 inhibitor. This specific combination is designated for type 2 diabetes patients who also have established atherosclerotic cardiovascular disease. If the clinical aim is weight reduction alone, the prescriber must transition to the separate obesity treatment pathway. NICE guidelines restrict semaglutide to these specific risk profiles, matching the drug's multi-system effects to patients with complex metabolic needs. Semaglutide is prescribed because it successfully integrates peripheral metabolic control with central neural regulation. By activating GLP-1 receptors at the cellular level, it improves glucose-dependent insulin control while simultaneously reducing central appetite. This dual-axis mechanism lowers blood glucose and promotes weight loss, altering both the glycemic and broader cardiometabolic trajectory of the patient.